I'm not kidding, 15 questions on the next test just off the sim. Because think about the education that happens after. Some of you didn't get to that point yet. There was a diabetic educator, but during the debriefing, you guys talked a little bit about what you would say or what you would do, and some of the education that would go with a type 1 diabetic and making sure that they don't have to be readmitted. So I would definitely look over that. And I just put that on Canvas for you. We are going to do kind of the similar activity that we did from the fall when you guys had pharmacology, and you had to do those stations. It's been a while, so some of you didn't save some of that content from Farm. So if you are wanting something that you remember, like the insulin table should be on here, but anything else from that test that you're like, I know I had something that helped me study and it was a handout, I can definitely get that to you if you need it or something. But this was the activity we did to kind of look at the medications with insulin, sliding scale, and I want to do it again because medications are another part of this test that are very high on the radar. So going back to your diabetic medications will be important. I also wanted to just announce for the 5K on Saturday, we're still looking for someone to be the Easter Bunny. So if you want to be the Easter Bunny, I will give you more points than people that are there doing, because I know that job is hard. Just having to be in there, but honestly, it's going to be a good temperature. It's not going to be super hot, but it'll probably feel pretty nice to have it on because you won't have to have much on underneath. And you just get to sit there at the finish line basically and cheer people on and give eggs to kids. So it'll be about an hour and a half of your time. So 10:15 to roughly like 11:45 is how long you have to be there. Take pictures with some kids. Probably my own. So kind of a funny story, I had to pick up the Easter Bunny costume last night, and did you hear this story? Oh, I told myself first, but I picked up the Easter Bunny costume, and of course I had my kids with me, and I had to think like, how am I gonna explain that the Easter Bunny's in this bag? And then I put it in the back, and my daughter had no idea, she was oblivious, and my son looks at it, he goes, how come the Easter Bunny's skin is in that bag? His skin. And I was like, well, it's kind of like Santa, like you need helpers, like there's not, 100 Santas out there. We just have to make sure that like the Easter Bunny has helpers, so then this is their helper, so this is not the real Easter Bunny. And he looked at me like, but is there a person in the real Easter Bunny? Like he was starting to really question things, and like, I just ruined Easter for my son because I had this Easter Bunny costume. But it did look kind of funny, like just all the skin hanging out. Poor Lord. So yeah, the Easter Bunny would be a good resume builder. I was the Easter Bunny for the 5 days. Anyone want to do it? My sophomores were kind of scared, but I'm sure some will show up and want to do it. Or I guess maybe I'll have to do it. Okay, so diabetes, the stations we'll do probably, I'll try to lecture the first hour and we'll kind of end with that and we'll kind of talk through some of that stuff. There is actually a lot of stations, so I would recommend you either get your iPad or like a blank piece of paper, number them 1 through, I think there's 22 stations technically. But some of them will take 10 seconds, right? It's not going to take very long. I don't have any drawing up to do. So in the fall, I had you practice drawing it up because that was kind of where you were at in the curriculum. I know you guys know how to drop insulin at this point. I know you guys can read an insulin syringe or how to do that mechanism. If you'd like practice with that, of course, use the open lab time, but that's really not the focus of today. And then there is a diabetic ketoacidosis, insulin drip back there to see what you'd see on your test. I should have almost included a potassium protocol too, like we can talk about that too. Yesterday during the sim, there was a potassium protocol, but we didn't have to use it because the potassium was poor, so it was considered okay. Okay, so continuing on, we're going to look at complications for diabetes. So we kind of talked about what would happen if your diabetic ketoacidosis occurred or your hyperosmolar hyperglycemic state would occur with type 2 diabetes. Now we're going to talk about the opposite side of the spectrum, so that low blood sugar. So with hypoglycemia, this is going to range from different person to person on how they present. So my example I give you is that people that don't have diabetes, they might be in the 60s for a blood sugar and be symptomatic. So this is when we feel like that hangry feeling, where we feel irritable, you feel kind of shaky, you might even feel like you can't function or you can't concentrate. Okay, when you're hungry, it does take away from some of that cognitive function. Now a diabetic, however, who it kind of ranges from 50 to 550, right? They're all over the board. Sometimes they become immune to that feeling, where they happens every single day, happens all the time. So you could have somebody with diabetes be in the 40s and be sitting there watching TV feeling fine, okay? So hopefully they will have some type of symptom system that will say, check my blood sugar. But if you're ever curious or ever concerned that someone just isn't quite right, a blood sugar is an easy thing you can do that no doctor is ever going to yell at you for checking a blood sugar. Because typically, even if they don't have diabetes, it's worth checking to see if something's off with their blood sugar. Because what if you were diagnosing someone for the first time, or maybe they were getting a lot of steroids or a lot of things that increase their sugars, that you'd want to check it to make sure something's not quite right. So blood sugar, even though you do need orders for blood sugars, I have never seen a doctor be mad that you checked their blood sugar because someone seemed funny, like they were acting odd, okay? So hypoglycemia, 70 to 100, I was talking about this with my sophomores, but 70 to 100 is our normal where I want you to memorize for this test. You will see some resources say 70 to 110, but the American Diabetic Association, which is the head of all diabetes, says 70 to 100, okay? And the reason why they use 70 to 100 is because once we start diagnosing diabetes, we need a concrete range so we can say, okay, if they're between 101 and 126, they're considered pre-diabetic, right? So it's more consistency across the board. But 70 to 100 is where the goal is. Now we talked about in the fall that when you have this blood sugar, it's a fasting blood sugar. It's not when you just ate. So if you ate something, this is going to be a little higher, and that's normal. But everyone in this room's blood sugar should go back down to 70 to 100 within an hour or two. It should not be 6 hours later and you're still 160. That's considered probably concerning. So they usually say 2 hours. If you have not eaten, it's a pretty good accurate fasting blood sugar because your body should produce insulin to bring that sugar back down. So with hypoglycemia, if you feel like the person is having those symptoms consistent with the autonomic nervous system response, aka your fight or flight, so your epinephrine. So remember, epinephrine was one of those hormones that raise your blood sugar. So why would epinephrine be released when your blood sugar is low? It's trying to raise it. So the whole point of epinephrine is to help with the sugar. However, there come side effects. If you have a stimulated epinephrine, that's why you feel heart palpitations, tremors, sweaty. You're kind of feeling some of those things. So a lot of times they get jittery, sweaty, and they just kind of lose that cognitive function too. So hypoglycemic unawareness. This is when you have those diabetics that they've kind of lost that feeling of having low blood sugar because they've had it so often your body goes, you know what, this is the 20th time this has happened this month. It's not a big deal to me. But when you have a person that does not have diabetes, they're going to be symptomatic because their body's not used to it. People that have hypoglycemic unawareness have a very high chance of death because they don't know they're having low blood sugar. So you could probably agree that people that have diabetes have a higher chance for high blood pressure. There's a chance that they're going to be on medications that are going to mask those signs. So think about like beta blockers, and those are considered calming down the epinephrine in the body. If it's calming down the epinephrine, what's that going to do to your signs of hypoglycemia when you're having the hypoglycemia? It's going to mask it. They're going to say, if you're taking a beta blocker, that is decreasing your sympathetic nervous system, the epinephrine. So if your blood sugar gets to 50 and you're on a beta blocker, you're not going to have the sweaty, the jittery, the heart rate increase. So maybe it would be missed because of the beta blocker on top of that person. So always assess your meds to see kind of what you're dealing with, and it'd be something just to be aware of, where those are the people that should get their blood sugar checked no matter what. So you probably have had a diabetic come in and they go, I only check my sugar once a day, or if I feel low, they'll say I feel low. But if you're type 1 diabetic, sometimes you don't feel those things. So you wouldn't even know you were low unless you checked it. So type 1 diabetics should have a minimum of how many times a day? 4. Meals and bedtime. And that's the minimum. So that's a lot of poking. So what is a nice feature that's come out in the last 10, 15 years that you don't have to poke yourself every 4 times a day? Yeah, it's like inside the fat, it's called a Dexcom, that's a brand name. But basically what it is, it's a sub-Q needle that sits there all the time, and it measures your blood sugar and goes to your phone. So they can check their blood sugar all day long without getting poked, essentially. One time, it's in there, it stays in there for a while. I'm not sure how often they change that needle, maybe once a week, but it's not very often. And you can swim with it, bathe with it, it's really universal that way, so you don't have to worry about taking it off. Okay, so what do I do if my blood sugar is low? So if the person checks their blood sugar and it is low, I like to say keep this kind of in the background, but you're going to do a lot different things with a 68 versus a 38. we have to consider, once we take our blood sugar, what does the person look like? You could have diabetic patients who are used to having this low blood sugar, that's a 38, and be talking to you, coherent. So if the person is coherent, able to protect an airway, you can feed them, okay? So I do want you to use this as a reference tool, but not the only tool. Because if you have a 38, and again, that is pretty low, but let's say even a 58, it doesn't mean you need to go get dextrose or go get glucagon. It's only if the person is incoherent, or they're slurring their speech, or they're lethargic. Those are ways that you say, no, I'm not gonna put something in their mouth. So when the person has a low blood sugar, you give 15 grams. You do not need to give 100 grams. If you notice, people that are diabetic will say, I'm gonna eat a whole Snickers bar when I'm low. But really, there's like 60 grams of sugar in there. So now we're gonna have a different problem. So they raise their blood sugar, and then they go 200 grams past it. That's not really what we want here. So we want to have small amounts of sugar that will do the job, because it's fast. We don't want the complex things here, just simple sugars, to raise it but not go too high. And if the person is very low, typically when you're less than 50, you're gonna start to need more intervention, like the dextrose or the glucagon. This is pretty unusual that someone would be 38 and be symptomatic. That'd be very unusual, but it could happen. Then, these are kind of times too where sometimes diabetics will get into this low state. They maybe gave themselves too much insulin and they pass out. These are the people that are playing basketball or something where they are diabetic and maybe they gave themselves too much insulin. Exercise actually burns sugar, so they could become too low and pass out like on the basketball court. And they come in, they find their sugar to be very low, and they give them that sugar to help them. Okay? And then different drugs that might cause it. So one of the drug classes you'll have to know for this test is your sulfonylureas. Do you remember anything about the sulfonylureas? It's a type of med we give for diabetes. So what does it do? How does it work? Is it Max? Nope, not the liver, that's metformin. So because sulfonylureas can cause hypoglycemia, it actually stimulates insulin to be released from your pancreas. So this is one of the special drugs, sulfonylureas, where it's probably the only one that actually helps bring the insulin out of the pancreas to work. So sulfonylureas have the highest risk for hypoglycemia. And I would definitely know that for your test, because people that are on sulfonylureas will tend to have lower sugars than people on like metformin. Metformin does not really cause hypoglycemia. So it'd be different for what drug they have. Okay, so I don't think every sim group got to see this, but maybe I'll bring it in when you guys are doing your stations. But dextrose, those amps of D50, the actual medication that was on your list for your sim, it said D50, and it might even said an amp of D50. So if you don't know what that is, it's a 50 milliliter syringe. So it's a big syringe, and it's full of 50% sugar and water, essentially. So it just increases your sugar fast. It's like having a couple bites of a Snickers bar. It's essentially the same thing. So the 25 to 50%, depending on what your doctor prescribes, will be given through the IV. We do not give dextrose through the subcutaneous tissue. And then glucagon can be given subcutaneously, IM, or IV. Typically, though, in the hospital, we will give dextrose because it's the most available. Glucagon is home. There is times in the hospital where they have glucagon on the MARG for PRN and dextrose. So when would you use one over the other? So why is glucagon on there if you have dextrose?
You don't have an IV.
Yeah, your IV goes bad. Wouldn't that be terrible? During a hypoglycemic reaction, your IV falls out or goes bad, then we have no route. We have to have glucagon on there for a backup in case the dextrose is not able to be given. So there will be times where it's there. Okay, so complications long term. I think we could probably agree most people in this room have seen complex diabetes when they start to exhibit those side effects, those symptoms that are gonna happen for long term. Nobody has diabetes for 1 year and all of a sudden they lose a limb. That does not happen. It takes time for this to happen. So yes, this can happen in type 1 diabetes if they do not take their insulin and do what they're supposed to do. But a lot of times type 2 diabetics, they maybe are just running their blood sugar too high for long periods of time. They take their pill when they remember, and it does become an issue. So we can have macro or micro circulation issues. The only difference is macro are your big vessels, micro are your small vessels. So I always say that you can have macro circulation issues with you could have an aneurysm, like those big vessels that are gonna become clotted with sugar. Or your tiny vessels in your eye, like those are the micro circulation. So what is some things that you've heard about diabetics What are some complications that you've heard of or seen? Blurry vision or blindness. You literally can go blind. And you have to think about, if you have a ton of sugar in blood, it's sticky and it's become irritated. It's irritating that vessel, which is destroying these microvessels in the eyes or the kidneys. Okay? What other things do people say? I feel like this is the number one. Ulcers. And this is more of your neuropathies. They cannot feel their extremities, like their toes and their feet. So, and their circulation's poor anyway. So when your circulation is not good and you're sitting with your heel on the bed all day, you're gonna get an ulcer. Or they might hit their toe on something, break it open, they don't feel it for a couple days, it gets infected. So a lot of times diabetics have foot care and skin care. It's a huge priority. So this test, when it comes to diabetic complications, I would know all those things to prevent ulcers in any population, but especially diabetics. So making sure you're repositioning, checking their feet, cleaning their feet. We've all seen those people's legs and skin that just, they do not cleanse their body. And then making sure that we're kind of avoiding some of those hurtful ways to become open in the skin. So wearing shoes around the house, they might have to do that. Or potentially, you know, if they're checking their feet, going on the bottom, not putting lotion in between their toes, that can create infection, right, between there. It has that moisture. And then even just diabetic foot care, hot water, they don't feel the hot, they can burn themselves. Like making sure they use just kind of like a lukewarm water. And then think about that metabolic syndrome. They have the hypertension, they have obesity, diabetes is usually there, and they have all these components together that could cause heart attacks and strokes. They have very high risk for those things. What color is their skin typically when they have diabetes in their legs? This goes hand in hand with peripheral vascular disease. What does it look like? Do you ever notice that their legs aren't hairy? Have you ever seen this yet? Their legs are like smooth, like they shaved their legs. Why does no hair grow in peripheral artery disease? You need blood flow, right, to grow hair. It's like if you have a seed in the ground, you need sunlight to grow that seed. It's the same concept. Blood flow is poor, they're not circulating as good, it's constricted in those areas because of hypertension, that's why there's no blood in there, and it causes like that discoloration of the skin, the hairless skin, it's almost like shiny, and then it becomes very thin to the point where it can just tear open, and that's why they have those ulcers too. Diabetic retinopathy, so this is the blurry vision or the losing your vision altogether. This happens a lot. So if you've had diabetes for more than even 5-10 years, the chances of having blindness are very high. And if you do not have sugars that are nice and regulated, it increases the risk too. So diabetics a lot of times will say this: I take my insulin, but I also eat like crap. So you want them to be 70 to 100, but they go from 70 to 500, back down to 120, then to 440, then down to 50 because they forgot, then up to 500. Okay, so they're all over the board. That is not a good diabetic just because you happen to get down to 70 to 100 because you took your insulin. You have to maintain a very close range. So they want you, good diabetics will say 70 to 150. You're always in this range. So what is the person doing? They're eating healthy and not just eating a bunch of carbs. They're taking their medications. They might get a little high after eating, but they go right back down because they take their insulin. They don't have a cheat meal where they just go, eat everything, okay? Because that is gonna cause you to bounce around like this, and that's what causes these nephropathies and neuropathies in the retinopathy. All these things in your vessels in your body, okay? This is always a catch-22, but diabetes will cause kidney failure eventually, especially if you are not staying manageable and taking your meds and doing the things you need. However, the medications we put people on with diabetes can cause kidney failure. So this is what's hard to treat people with diabetes, is that a lot of times they have high blood pressure and all these other things that a lot of times their medications expedite their kidney failure. So they have the condition of diabetes and they're taking meds that could harm their kidneys, boom, they have kidney failure. So again, the chances of having dialysis as a diabetic patient is very high as well. So it kind of goes with that metabolic syndrome where it eventually causes other organs to fail. I don't think I've met a diabetic who doesn't have high blood pressure. I don't think I've seen it. It's always hand in hand together. because it commonly comes together from diet and lack of exercise. Okay, this just kind of shows you the neuropathies. It just shows you kind of what happens in the body pathophysiologically. But if you have nerves that are innervating your muscles, and there's a high sugar content if you release it, and eventually it deteriorates that nerve cell, and eventually you won't be able to feel. So they'll always have this feeling of like tingly almost, or numbness. It's not that they can't feel altogether, it's just decreased, and sometimes they'll just feel this sensation in their feet, and it's not a good feeling. It makes them not be able to sleep, it's painful, and eventually it will become a point where they will lose functioning. If the circulation is so poor, and they keep getting these ulcers in their extremities, what will happen to their extremities? What's that? I think you said it. Amputated. Yeah, it's very common. Bilateral amputees, I'm sure you guys have seen it. One person had this a couple weeks ago. But I don't know if they had diabetes, but typically when someone has a below the knee amputation, it's almost always because of diabetes. And I hate to say this, but sometimes it's easier to cut the foot off than it is to be in the hospital for 12 months managing all these infections and trying to become septic and all these things. And it's not the doctor taking the easy way out, it's saving the patient's dignity and having to live in a hospital for that long time. However, even if you amputate the foot, does that change the diagnosis? No, it just kind of fixed the acute problem. But I think there was a patient last semester, she came in and they claimed this, I don't know if this is true. She had never seen a doctor and she was like 60. She had never been to the doctor. It was one of the boys in this classroom, because I remember, I think it was Max. Remember her feet? There was a girl that had feet and it was just like, her toenails were super long. Who was that? Or is it Adam?
I think we had the same.
And the toenails were super long, like she had to cut her toenails in like, it had to have been like 5 years. they were like 12 inches long. Yeah, they were like growing into her foot, and she had like just gangrene is probably what I would have called it. And so what they had to do is they had to go up to surgery, cut her toenails in surgery, but also like clean up all and debris, all those wounds, because she was having those wounds. So she was a diabetic, but she was just one extreme of the spectrum, just kind of like go taking care of yourself to completely don't even look at your feet ever again. So hopefully we can go somewhere closer to the other side to not have those issues. I would know what paresthesia means. You guys learned that from respiratory alkalosis. That's kind of the tingling in your feet. It's a nerve thing. And these paresthesias can happen in your feet and your hands. Sometimes they'll feel them in their hands too. All right, infection is obvious. We've kind of talked about that already, but infection is going to be higher in diabetes. And really the lack of blood flow is the reason. So they don't have this good, adequate blood flow, maybe because they have the hypertension as well. But you need to have circulating blood to kind of perfuse the areas that need to be perfused so you don't have that infection. And then teeth. A lot of times when they go into dental procedures, they will prescribe antibiotics for them because they have a high chance of getting like cut on the gum or having like an abscess that actually gets infected, and they already have a high risk of infection anyway. So a lot of times these patients will be put on antibiotics before those dental procedures. That's very common. It's kind of like surgery. When you start them on cephalosporin before surgery, you anticipate there'll be an infection. It's really high risk. Okay. So let's think about the feet. And you never thought feet would be such an important part of the test, but it is. We talk about feet a couple times on this test. How do we provide foot care to diabetics? So I've said a couple, but what is something that you would educate your patient on?
Having them check it if they can.
Okay, checking your feet. How often do we check? Every single day. Not every other day, not every week. Now, I want you to think about your own foot care. Okay, think about when you shower, whatever. How often do you look at the bottom of your feet? You look at them every day at my feet. Like actually sit down and go like this and look at the bottom of your feet.
I do the shower and I'm like cleaning.
You go like this and you look at the bottom of your feet like this?
No, I like hold my leg and scrub it with my scrub.
Okay, maybe so, but think about the average person. Probably does not look at the bottom of their foot. And now they have diabetes where they're higher risk, where they might just let that go, or they don't shower. You gotta realize this too, people don't shower like younger people. Sometimes older people shower once a week. Okay, so it might be very uncommon for them to check the bottom of their feet. Now, think of the typical type 2 diabetic. Are they trim? Again, not stereotyping, but typically truncal obesity is going to cause the type 2 diabetes. So maybe they can't sit someone else help them check because they can't actually look at the bottom of their foot, okay? Another way, and this is what you should be doing on assessment too, but when you have your hand, and they can feel in their fingertips, usually more than their feet, they should run their hand on the bottom to assess for any open wounds if they felt something. So a lot of times when you guys are in the hospital and a patient's lying flat supine, and you think about their feet are just kind of dangling there, how often have you just looked, assessed pulses on the top, but you didn't look at the heel underneath? Happens very commonly. And I always wear gloves just because I don't want to put my finger somewhere and find something, because essentially that could happen. So if I want to assess someone's feet, I might put gloves on and I just run my hands down the bottom of their heels, because that's where the ulcer is going to find, right, or happen, is under that heel where the heels are touching the bed. So we tell patients to run their hand along their foot so they can feel for any holes or any types of wounds. Okay, so when you're in the shower, what kind of temperature are we looking for? I just love a hot shower. Everyone just like, I could almost get burned in the shower. I love it so hot. Like, I want that shower to be so hot that I'm like, ooh, it kind of hurts, but I like it. It's like, I want it to be hot. My husband's the opposite. Like, one time I like felt his shower, and I just kind of explained too much there. But I felt his shower, I was like, this is crazy. Sorry, I just totally just gave away a lot of things. But anyway, it is cold. And I was like, damn, this is cold. And he's like, what the heck? And then he felt my shower, and he's like, oh my God, I'm burning to death. Sorry, I'm young too, guys. So, oh, this is awkward. Maybe we should take a break. All right, now you're listening. The people that weren't listening are like, oh, listen now. But if you have a hot shower, what's going to happen? They're going to get burned, right? So we have to realize that people are going to not be able to feel that hot temperature. So there are ways, and they ask this to kids that come into pediatric visits, you can regulate your temperature of your water. So the water heater downstairs in your basement or wherever the water heater's at, there's a function on there that you can, well, maybe the newer ones, that you can say do not go hotter than 120 degrees. And you probably have noticed this if you went to other people's houses, but some are like, damn, this is really hot. Like, how is it even this hot? And then like other people's houses don't get that hot. And the reason why is because the water heater has a regulator that it won't go above like 100 and whatever, 20 degrees. So why do we want that in peds populations? It's the same concept for diabetics. They don't know like what's hot and what's cold, and they might turn on the bath water and it's going 160 degrees, they're gonna get burned. Same concept when it comes to diabetics. If you do nothing over 120, you know that they're not gonna get burned, okay? Usually you can't get burned from 120 or lower. Okay, so then what other things would we do at the feet once we're out of the bath or shower? Yep, completely dry it. So they should take a towel and really dab their feet and make sure they go in between their toes, because they could get like a fungal infection that would kill them. Literally something simple could kill a diabetic if they have a high risk for infection. So drying very well, and then we always tell them you can put lotion on your feet, but don't put it in between your toes. It just causes too much moisture. So avoid that. And then we usually say stay away from scented stuff. What would scented soaps or scented lotions do to their feet? It can irritate it, or it can dry it out further. So if you've ever heard of like bath and body soaps, they smell good, but they don't help with hydration. They really don't do anything except for make you use it 10 times more, which is kind of the concept of using it, and then it dries your feet out, or dries out your body. So they try to say like the CeraVe or the Vaseline, some of those things that are more like hydrating and not scented. Any other thing for feet? I don't think there's anything else. No, that's pretty much it. But checking them, cleaning them, and making sure they're dry. All right, this kind of goes too with some of the skin as well, but when they have ulcers, we think of if you have like a little tear of the skin, how long does it take to heal? Say you cut your finger cutting an apple or something, and you got like a superficial cut, it burns, it hurts, you didn't cut anything off, but a little bit. Yeah, a couple days, maybe a week, 7 days if it's a little bit deeper. In a diabetic, multiply that by 4. So even if they have a very deep wound, it's gonna think about tissue, granulation, how you actually grow your skin. It takes a long time for an ulcer to heal, like sometimes even 3 months if it's a deeper, like stage 3 ulcer, if not 6 months to a year. So diabetic patients can have these ulcers for a year before it actually gets back to where it needs to go. And that's if they come into the hospital to get treated. Or they're actually having someone like pack it and cover it and clean it, those things. So it's very common that could happen and turn into a really bad ulcer. Theirs also gets worse 4 times faster. So if they have that ulcer in the bottom of their foot, And if we didn't see it, you know, we're young and healthy where we could probably kill off any infection or fight it and close it within a couple days to a week. Theirs is not like that. It could get worse 4 times fast. So they think that, oh, I check it every week, that should be good enough. That's enough time for it to become a really bad ulcer. I love to bring this one up because students never know quite the answer, but can we cut toenails?
No. Well, nurses can.
They physically can, we just don't really. In a nursing home, maybe, because it's a long-term care setting, but in a hospital, I would not because they're acutely ill. So think about the setting. So if it's an acute, they're having an infection, or they're there for a more acute reason, we usually try to stay from cutting unless a podiatrist or surgeon cuts them off. Now, long-term care, where they're going every single day, they live there, they're healthy, they're not actively sick, that's a different story. We could do it then. Now, if it's very thick, and to the point where it does not help with like an actual just normal cutter, we typically try to stay away from cutting those. But if they are just a standard toenail, you cut across. You never do a circle, like how we kind of like do the half moon and like go around. You just cut across to keep them short. The reason why is because you could cause ingrown nails, or like it could cause it to like cut on the side of their finger or toenail. So me being the nurse that I am, I got a pedicure one time, and you know how they do your toes, whatever, and they cut your toenails. And I go, obviously my toes are fine, but I was like, do you cut everybody's toenails? Like anybody and everybody? Because there was a lady like 3 or 4 people down that looked older, a little more fragile, and I'm like, what if she's on a blood thinner and you cut her toe and she bled to death? I'm just thinking this stuff. Or diabetic and they didn't cut across because they do like the half moon there. They use like their little thing that like shaves it down. But I was like, you could really cause damage here if you think about it. Or if the person punctured their skin and they had MRSA, and the MRSA was on the peds like little pot of water thing. Like there are things that could happen that maybe they don't think about. And I asked them and they were like, lady, what the heck are you talking about? I was just like, I'm just curious, do you cut everyone's toenails? And they're like, well, yeah, that's why they're here. I was like, what if they have like medical problems? And she's like, I don't understand. Like, I don't understand your question. So just think about that though, that those kind of settings could cause like infection and open sores and bleeding and things that might cause more infection too. Yeah, my brain goes different ways sometimes.
Can you delegate the cutting?
To like a CNA? Yeah, you could. It does not require any background and knowledge. I would just have your CNA be aware of the condition so they would know. But if it's someone like in long-term care setting, it's gonna be something a CNA does. It's not gonna be out of their scope. So yeah, they could. I personally have never cut someone's toenails because I've never worked in long-term care, and I would never touch in an ICU.
You don't want to?
They don't allow sometimes. Yeah, they don't
Yeah.
allow.
I think if it's within, like, you gotta think about the person too, like how complicated they are. You've seen the older people that don't have a lot of comorbidities. They are healthier people that might just be there. And of course, they probably are doing their own. Think about that. Like they're probably able to do it. But some that maybe just can't reach is too dependent on where they work and where they live. And by the state. Every state regulates different things they can do too. That is not something I would ask on a test. It can vary. Alright, so what can we do? So do you remember in pathophys, there was a triangle of diabetic management? There was 3 things that looked like this, and then there was a circle that makes the whole world go round. Do you remember this? It was yellow. I'll have to find it during our break. And there's 3 things that make diabetic care go around, and they can prevent up to 60% of the complications. So if they do these things, and they do them well, now again, they still have the diagnosis of diabetes, they can try to prevent complications by 60%. So meds, exercise, and diet. What makes the circle go round? Blood sugar checks. So notice that the reason why it goes in a circle here is because you have to check your blood sugar consistently 3 to 4 times a day while exercising, managing your medications, taking your medications, or eating the diet that you're eating. So that should kind of make sense that you eat typically 3 to 4 times a day. You're going to be checking your sugars before giving yourself insulin and eating. If a diabetic is going to exercise, they should check their sugar before in case they're low, and then making sure that you do that on a consistent basis. This is the heart and soul of diabetic care. If you think about your boards, they're going to ask one of these 4 things. They want to know about the meds, they want to know about blood sugars and how to diagnose, when to check, they want to know about exercise and how that affects it, and think about all of the carb counting and things that go with your diet. Okay, so it is pretty much well managed by those things, up to 60%. Okay, this slide is not new, it looks busy, but we're gonna talk about how to diagnose diabetes. Let's think back to pharmacology. There was a question, and it said basically a person is getting diagnosed with type 1 or type 2 diabetes. Which of the following lab work is consistent with a diagnosis? Okay, so why is hemoglobin A1C the king of all meds, or the king of all labs, excuse me?
Goes back 3 months.
It goes the last 3 months, and it's an average. So why is a fasting blood sugar of 98 not good enough to be consistent? Let's say the person has diabetes, and they're there for their 6-month check. We will do a fasting blood sugar, absolutely, but we're gonna be looking at this more so to see how they're managing their care, right? We're gonna see this because what could they have done before this visit? Took insulin, right? Theoretically, they could give themselves insulin and be back to 70 to 100, and you go, good job, your blood sugar is 70 to 100. That is great that they're that low. However, if we get the hemoglobin A1C and it's 10%, now we say the lie detector determined that that was a lie. Okay? So fasting blood sugar, I'm not saying it's something we don't check, we absolutely do, but the hemoglobin A1C tells us the consistency of how they're taking their meds and how they're managing their blood sugar. So when I wrote on before, it said 70 to 150 to 500 to 250 all over the board. This is going to take an average of that and tell you what it really is. So I would be probably in like the 200 to 300 range if I would have had those sugars from before. Is that good? No, that's bad. That's going to cause your complications, like your blood flow issues, your nerve issues, your eye issues, kidney. Those are all going to be affected from that. Okay? So I did say, here it says 70 to 110. You will have different ranges. The American Diabetic Association wants you to know 70 to 100. So I'm just going to stick with that. Your textbook said 70 to 110, which is why that's on here. So why do I care so much about 70 to 100? Because I might give you this on your test. You have a fasting blood sugar of 114. Okay? So let's think through this. You have a fasting blood sugar of 114. Are we going to start getting that insulin and metformin ready? No, we're not doing that. Okay? Now, if the hemoglobin A1C, what is normal? 4 to 6%, somewhere in that range. Let's say we get a blood sugar, a fasting of 114, and your hemoglobin A1C was 5.9%. And let's just say that's what came back. First of all, they do not have diabetes. They have pre-diabetes. What is 2 things we're going to probably encourage them to do? Diet and exercise. Come back in 6 to 8 weeks. We'll check this again. Try to lose some weight. Try to eat more consciously. Maybe they're drinking a lot. Maybe stop drinking or limit your drinking. If you're smoking, limit your smoking. Some of those things can be changed if they come back and they're at 79 for blood sugar and their hemoglobin A1C is 4.6%. Guess what? They just prevented diabetes and they don't have to be on anything. It happens more than you think. If a person gets a diagnosis of pre-diabetes, it scares them because they're like, I don't want to be on meds and insulin and all this stuff. And they go lose how much percent of their body weight? 5 to 10% usually, not that much. Okay, maybe 10, 15 pounds, 20 would be great. They are going to lower that chance of getting that diabetes. Okay, I can guarantee you if my fasting blood sugar was high, I would probably be doing some stuff, right? Because you want to make sure you're healthy. You want to live a good life. Okay, so when you have a diagnosis, this also gets a little touchy. I know that diagnosis of diabetes can occur with a fasting blood sugar of 126 or higher. However, what if you were at 127? Doctors are not going to probably put you on meds unless it's the 2nd, 3rd, 4th, 5th time this has happened. If this was your first time ever getting a fasting blood sugar and it was 127, the doctor's probably still going to say, go try to do environmental things first. Let's just try it. Nobody's going to die of a 126. Okay? So go help yourself. Come back in a month. Come back in 2 months. Okay? You're not going to have a 500 blood sugar in 2 months. And then if they come back, they were at 128 and now they come back and they're at 135, then we're probably going to start thinking about more medication. Okay? And what is probably the most common med we start everybody on if they have type 2 diabetes, not type 1? Metformin. Everybody gets it. Every single person. Guess how much metformin costs? a month, maybe $4 a month. It's on the $4 plan for Walmart. So it's cheap, it's effective, it works great, okay? Most people will be put on metformin for a diabetes diagnosis, type 2. Okay, when would we use, oral glucose tolerance test? There's only one time we use this.
Pregnant.
And when I wrote on the board, it said type 1, type 2, and then I put on the side, gestational diabetes, okay? So you will learn in the fall, this is not OB class, I'm not gonna teach you everything you need to know about OB. However, when the person becomes pregnant, they have a chance of having diabetes gestationally, and if they meet the requirements if they have like an obese BMI, they will test them earlier, but let's say they just have a normal BMI, when would a woman be tested for diabetes? How many weeks gestation? Anyone know?
12.
So we normally have 40 weeks in gestation, right? When do women typically get to come into the doctor for their first visit? About 8 weeks. Why do we not do it before then? You can do a pregnancy test, but you can't tell if there's a heartbeat. Okay, typically we wait till 8 weeks, sometimes even up to 10 weeks, depends on the person. So they get visits once a month until about 28 weeks, and at 26 to 28 weeks is when we test for it. Okay, so they'll do this oral glucose tolerance test where they'll give them sugar, and then they'll check their blood sugar 1 hour later, 2 hours later, and they want them to fall within these ranges. Okay, so after 2 hours, if their blood sugar is 149, they have a diagnosis of the gestational diabetes. They will repeat it if it's close. If it's way off the charts, they're gonna diagnose you. So after 2 hours, if you were like a 270, you have it. It's not wrong, okay? So that is probably gonna be a diagnosis. Now, if you're close, sometimes they'll repeat it and say maybe it was what you ate last night or things that you ate this morning. So they give them that 50 to 100 grams and then they check it. If it's within or over 200, it is a diagnosis of diabetes. Okay? And then what else is on here? Postprandial, what does that mean? Postprandial. You'll want to know what that means on your test. It means after you ate. So 2 hours after you eat, if your blood sugar is over 140, that is concerning for diabetes. I will say that the two things on this slide consistent with most diabetic diagnoses are the fasting blood sugar, just fasting. So you want to make sure you're not eating for 8 hours, fasting, and hemoglobin A1C. Those are the two things your doctor is looking for. They may do these other things if for some reason, let's say you made an appointment at noon, and you're in for something kind of unrelated, and then you bring up to your doctor and say, hey, I also think I have type 2 diabetes, like, or I feel like there's something wrong. And they do like a blood sugar randomly, and you just ate lunch, they have to consider that those numbers are gonna be off. So what would be a good thing for probably that person to do? Come back the next morning when you're fasting so we can get a better blood sugar, so a fasting one. Okay, other things that might come up with diabetes, really the three things, if you think about DKA, what were the three things that confirmed DKA when it came to labs? There's three things. It wasn't so much the A1C, it was just in general the blood sugar, right? Remember what it was yesterday?
700.
Like 700 and something. What about the urine?
What's the ketones?
Ketones? And remember how we measure it? 1, 2, 3 plus, and trace if there's a tiny amount, but negative is great, that means you don't. But 3 plus is the worst. Anything else? Remember the anion gap was on your last test. An anion gap is going to be part of your BNP. It's high. All that tells me is there's a lot of acid inside of your blood. That's all it says. So diabetic ketoacidosis, instead of drawing ABGs, they could probably just do this and they know you're in DKA. If they have these three findings, you're in DKA. And we already know that. We don't need a metabolic acidosis ABG to tell us that. Okay? A lot of times diabetics will test their urine every day for type 1. They'll literally pee into a cup, test it with a dipstick, or if they're sick days, they tend to have a lot more symptoms, they will become positive on that dipstick. Why is protein in the urine? And I said this with, if you have diabetes, it's not long before kidney failure starts to happen, or kidney issues. And if your kidneys cannot filter protein, it dumps into your urine, and it's a sign that your kidneys are suffering. okay, or your kidneys are not doing good. Protein should never be in large amounts in the urine, that's a bad sign, okay? Because proteins are really thick, remember proteins are big, and if those are dumped in the urine, your kidneys are not filtering them appropriately. So protein should not be there. And then the only reason we put cholesterol, triglycerides on here is because it's the circle of metabolic syndrome. If you have high blood sugar, hypertension, you probably have high cholesterol as well. It has to do with diet. Which electrolyte would be high with DKA? Think about what we did yesterday. Potassium, yep. And then we potentially could have that lower with insulin therapy. All right, why don't we take a quick break? I think what we'll